Okay, good afternoon, everyone. Come on in, welcome, find a seat. We are eager to get started. All right, good afternoon, everyone, and welcome to the Day of Academic Excellence at Women's College Hospital, where we have the opportunity to come together and really celebrate the ways in which we are revolutionizing healthcare. My name is Rachel Bosma. I'm a co-chair alongside Salmia Mayappan and Chandra Ferrer, and together we'd like to extend a welcome. We're really excited for this day. As our committee got together, we took a step back. I'm just gonna, does this move this forage? Do you have any idea where we, oh, here we go, there we go. Working out the kinks. Okay, as our committee got together to plan this day, we took a step back and we reflected on really what we wanted to achieve, what we wanted to bring our community here together. And as we look across the academic portfolio at Women's College Hospital, there's amazing things happening. And we wanted to leverage this Day of Excellence to bring us together and promote the breadth and the diversity of academic excellence. We wanted to bring the community together to talk to one another, to network and foster relationship. We wanted to continue to provide professional development opportunities. And we wanted to take a time to pause and to celebrate one another and celebrate the achievements that we've made over the year. And with these goals in mind, we have carefully curated an exciting program. But before we launch in, so here's the exciting program that we have in front of you here. But before we launch in, I do want to pause and give a land acknowledgement to start our day off on the right foot. So I work at Women's College Hospital in the city of Toronto, Ontario, Canada, or Takaranto, a Mohawk word meaning a place in the water where the trees are standing, a place where the fish are. For thousands of years, it has been the traditional land, the home of many nations, including the Mississaugas of the Credit, the Seneca, the Huron-Wendat peoples. Today, this meeting place is still the home to many Indigenous people from across Turtle Island. The streets that we walk on, so as I came here today, got out of the subway, walked up College Street, this is not just a street that I walk on to come to work, but it is an ancient portage trail that many have walked on before. And I think about the trails that my own ancestors have taken as they immigrated to this land and have brought me to Toronto, and I express gratitude for their journey, but also for the opportunity to be here. I encourage all of us to learn about the Indigenous people of the lands on which we live, work, or visit, and to educate ourselves continuously on the history of this land, to speak up for those who can't, and to act equitably in the spirit of truth and reconciliation. I'd also like to take a moment to acknowledge and to express thanks to all of us that came together to make this day a possibility. So this is a huge number of people, and I'm just gonna start us off by saying a huge round of thanks to everybody who dedicated their time off the side of their desk to make this event happen. So we have an exciting program, inclusive of a keynote speaker who's primed and ready to give his talk, poster and networking opportunities, oral presentations. So without further ado, I welcome Dr. Ruderman Lecture and Dana Maker to introduce this year's Ruderman Lecture.
Hi, thanks so much. This is only our third year of the Academic Day of Excellence, so thanks so much for coming today. We've included the Jim Ruderman Lecture because we really wanted to make sure that we addressed everything that he had contributed and led in innovation and leadership at Women's College, but also to highlight what is so important to him, which was also patience. So this lecture is actually held annually in honor of Dr. Ruderman, a much loved and respected physician who served in leadership roles as Chief of Staff, family physician during his entire career at Women's College Hospital. He was also a valued faculty member within the Department of Family and Community Medicine at the University of Toronto. He's remembered for mentoring generations of physicians in their early careers and inspiring many to champion change across the healthcare system, in particular Noah. So we're very happy to include Noah today as our speaker, and Dara will introduce Noah.
Hi there, I'm Dara Maker. I'm the Associate Department Head of Family Practice, and I was one of those people who was mentored by Dr. Ruderman. And it's my true pleasure to introduce Dr. Noah Ivers to give this year's Ruderman Lecture. Dr. Ivers is a family physician at Women's College Hospital, a scientist at the Women's College Research Institute, Innovation Fellow at Women's College Institute for Health System Solution. He is an associate professor at the Department of Family and Community Medicine and the Institute for Health Policy, Management, and Evaluation at the University of Toronto. And if that's not enough, Dr. Ivers holds a research chair in the implementation of evidence-based practice. His research focuses on the use of data to drive evidence-based, patient-centered improvements in healthcare. He has conducted multiple randomized control trials, systematic reviews, and qualitative work on health services and quality improvement interventions. He has won a very long list of research awards and has had his findings published in numerous peer-reviewed medical journals. Dr. Ivers is clearly passionate about quality improvement in primary care, and those of us who have the pleasure to work with him are regularly amazed by his ideas and his insights, and we are very privileged to have him here today.
Thanks, Dara. Rulan, thanks for inviting me. Those introductions never get normal. So I was asked to talk for a brief time about primary care and about some of the things that we're doing here at Women's or with groups affiliated with Women's to improve it. And I asked if I could, have like 4 or 5 days to cover that. And they said, no, you have 40 or 45 minutes. So I'll do my best. A little bit of preamble. Jim hired me, and much of what I'll discuss here really is inspired by him, the things he did, the things he said, and really want to start first and foremost by sort of recognizing the impact that he's had not only on me but on so many others. And so, with that in mind, it's a huge honor to speak at this lecture. And, in general, in addition to sort of standing on his shoulders while I try to see out a little bit further, I've had the benefit of lots of amazing mentors to guide me on various projects that I'll be talking about and make sure I don't go too far astray. So a little more preamble and a little bit more about Jim before we dive in deep. When I was just starting out, Jim won an award as the Family Physician of the Year. And just recently, I went, and it turns out that patient reviews about Jim are still available online. And I just wanted to highlight, this is not specifically chosen. This was just the first bunch that came on the page. He was recognized by his patients for his clinical skill. And I think really, really important to highlight that he was especially recognized for his emotional intelligence, both by his colleagues and by his patients. And that's sort of a theme that I hope to be able to come back to through the next few minutes that we have together. And so when I think about what made Jim an amazing primary care clinician, I think that he met the AAA criteria. He was accessible. He was affable. You never felt uncomfortable in his presence. And he was certainly able. If you had a clinical question as a colleague, you knew where you should turn. So, we start there when we think about what it means to do good primary care. We start with good clinicians, AAA clinicians like Jim. But, good clinicians like this are useless if they don't live in a team and in a system that supports them. And anybody who's done any kind of reading or thinking about primary care has come across a name called Barbara Starfield. Barbara Starfield sort of led a whole series of research and papers that showed that the quadruple C, the 4 C's listed there on the slide, are what's associated with better health outcomes at lower cost at a system level. And so when you have, internationally, if you look at primary care systems that achieve these things, that are accessible, that have good coordination, that offer continuity of care and comprehensiveness, then what you end up with is lower mortality, lower morbidity, and lower cost. It's a good deal. And so we actually do know what good primary care is. It's AAA clinicians working in a quadruple C clinic. So I could stop, I guess. So why does it matter? Why does it matter here in Canada? Why does it matter here in Toronto and in Ontario? The data suggests that on any given day, 10 times as many patients will be seeing their primary care clinician than will be presenting in Emerge. By far, most of the healthcare encounters in our system are with family doctors. And if that's the case, we need to make sure that those family doctors are AAA and supported by the quadruple C. Otherwise, we're missing opportunities. What's more is, over time, we have an aging population, and that aging population, the norm is now to be multimorbid. It is more common now to live with multiple conditions than to live with one. And so what people don't need is a specialist to go here and a specialist to go there and a specialist to look after this disease and a different one for that disease. They really need a quarterback to put the whole thing together. And this is increasingly true over time. And so just to reiterate a few of what I said, there was a wonderful paper in Canadian Family Physician Journal recently showing that, in general, most of the healthcare is offered in primary care. This is the home of complexity. Family docs cannot say, sorry, that's out of my scope. There's nothing out of our scope. We might say, well, we need to get a specialist involved, but ultimately that patient comes back to us again. And the data suggests that as we invest in more family physicians, more primary care clinicians writ large, I think we can actively include our idea of nurse practitioners in that list. What we get is an amazing return on investment, both in terms of health and in terms of efficiency of our system. But we have some challenges you've seen in the media. Yeah, so many people can't get family docs, even though we have more and more family docs. What's going on? It turns out we can add more doctors, more primary care clinicians to the system, but if they're not offering quadruple C kind of practices, if they're not offering continuity and comprehensiveness, if they're not accessible, it doesn't do us much good. And in many ways, this is a challenge that we can relate to. The job is getting harder. And so, people are finding, understandably, ways to work around it. We've set up a system where it's actually more and more difficult over time to be the kind of doctor that Jim was. What's the usual care model now sets us up, because of a lack of a system, for sort of running around like basically like a chicken with your head cut off. You're constantly reactive. Your patients are unprepared, and so are you for whatever encounter you're about to have in primary care. We don't have systems that prompt us. We don't have systems that prompt our patients. And so we end up with this very frustrating, frequently, interaction with our patients where we can't get done what we want to get done so that we feel good and they feel good at the end of it. And so who can blame them when family docs or other primary care clinicians decide to sort of restrict their practice or find alternative ways of having a halfway decent day? Because the family docs that keep on trying to slug or walk uphill against this non-system, they kind of look like this guy, a little bit frazzled. And it reminds me of this famous painting, The Scream. It's often how I feel at the end of my day seeing patients, because the system's not set up to make things easy. And it should be. It really should. And so, we can scream or we can decide to do something about it when we're done screaming, or both. And so, innovation is bound to happen, and we're glad to see it. We're very glad to see it. The pandemic brought out tons of innovation, which some of which we're really, really proud of. My close colleague, Dr. LaPointe Shaw, has led a series of work looking at a bunch of innovations around virtual care. And what I'd like to say about this in general is that while virtual care is care, when it happens distinct and separate from the rest of the primary care system, all it is a Band-Aid. We've identified an abscess, and we've gotten annoyed that there's a little bit of goo getting on our clothes, so we stick a Band-Aid on it. What we found is this unintended consequence when we don't deal with the real problem, is that we offer these separate innovations that aren't integrated, we end up with more emerge visits and more disintegrated care. And so, sometimes the simple solution is not really the desirable one. That's probably the most controversial thing I'll say today. Something that is, not new at all, I'm nowhere near the first person to say this, is that a better solution is to build primary care teams. This image comes from the Institute of Medicine, and, various smart folks around the world have made similar images. And so instead of this very frustrated fellow on the left of the screen, what you can have is a most responsible clinician, whether that's an NP or a family doc or what have you, together with the patient in the center of a circle supported by a system. And I'll highlight also that smart people are starting to recognize that that system should include not just a medical office assistant and perhaps a nurse, but it should include the community pharmacist and the social worker and the community health worker and so on and so forth, so that we're integrating social services alongside medical services so that people get what they need when they need it closer to home. This is not a new vision, but we keep avoiding the need to invest in it. But we need to because there's still about a quarter of family docs in this province. Again, most of the primary care, most of all care is delivered by family docs in this province, working in offices basically alone, trying to manage best they can in this non-system, and it's literally impossible. It's hilariously impossible. If you look at the data on this slide, this is from the States, it literally would take more than 24 hours in a day to do all the things that this doctor's patients need. What can we do? So things get dropped. Which things get dropped? The preventative care and the chronic care, because the patients coming in with acute problems need to be seen today. It's urgent. And so we keep digging ourselves a deeper hole, falling further and further behind. The math says that if we can delegate a little bit more, or quite a bit more, a bunch of these preventative and chronic care things, then we can manage a team more effectively, and the most responsible clinician can actually sleep, which would be nice. And we saw that in Ontario really, really clearly during the pandemic. Patients looked after in teams had higher vaccination rates, better chronic disease management, better preventative care, lower hospitalizations, on and on it goes, compared to patients not managed in teams. Not only that, but the clinicians working in the teams had greater capacity to pivot and get involved in the public health response. Teams make a difference. The government's starting to listen. God, hallelujah. So the government's starting to listen and is investing what I think is a bit of a drop in the bucket, but it's a start. And we're getting a whole bunch newly funded primary care teams in this province. And not only that, they're listening to something else we've said, which is to say, hey, we also need to evaluate as we go. And to their credit, we're helping them do that, which is exciting. And so this sort of step one of the presentation. And I just want to sort of, for a moment, change gears to step two, because if we get these new teams and suddenly patients have access to care, they're not one of those 6.5 million Canadians without access to primary care, that's great. But it doesn't mean that they've gotten good care. I have a friend who, his family doc, he can't get in for weeks at a time, months sometimes. His mom's family doc, he can get in right away, but he doesn't trust what will happen will be useful. So, Jim actually spoke about inappropriate variations in care now 31 years ago, published in the Canadian Medical Association Journal. And he focused on obstetrical care at the moment in that paper, but it applies to so much of medicine, which is that what happens when you see your clinician may not be the same as what your friend experiences when they see their clinician for the exact same problem. That's a bit concerning. It's sort of like, most of the population assumes a high level of technical care for their clinicians, which is great. We want your faith. We want to earn that faith. But it's, if you ever watch The Wizard of Oz and they pulled back the curtain and you see that it's a little bit problematic. So Jim talked about this 31 years ago. And, inspired by that, most of my career has been about something called implementation science, which is where we try to basically figure out the reasons for inappropriate variations in care and try to solve it. But one important counter-insight from family medicine is that sometimes variations in care are perfectly appropriate. Sometimes a good clinician knows what the guideline is and decides to deviate from it in this particular case for this particular person based on their values, their preferences, or their particular situation. That's good care, even if it doesn't follow the guidelines. So which is the case? Which is the case? What's going on? When we look recently, this is a paper published by my good colleague Jen Schuldener very recently in CMAJ. What we see is not purposeful variation. If we look at vaccination rates, we see that there is a disproportionate number of patients unvaccinated for COVID-19 set in a small number of primary care practices. These primary care practices tended to serve the populations that were lower socioeconomic status, more likely to be large practices, having poor access to care, and more marginalization. That doesn't sound like purposeful variation to me. I hope not to you. What it sounds like to me is another enactment of something called the inverse care law. The inverse care law was written by a guy called Tudor Hart, John Tudor Hart, 60 years ago in the UK, talked about how patients and populations and practices that most need extra services don't tend to get it. The ones that tend to get it are the ones ready and able to receive it, which is inverse from what we want in a good healthcare system. Diabetes is usually the place where we look for inappropriate variations in care. It's just really easy to measure. Lots of people have it. And it seems like every time we look at diabetes care, we see that patients are having inappropriate variations. So some patients get their cholesterol lowered, others don't. Some people get to their sugar targets, other people don't. And there's no seeming rhyme or reason for who gets what. For example, the most common cause of blindness in our country is patients living with diabetes that don't get their retina checked. This is pretty, unacceptable. So, what can we do about it? Turns out there's been, 500 randomized trials of people trying different quality improvement strategies to try to solve this problem around improving diabetes care. A big subset of those tries to figure out how we can improve this eye screening so that nobody goes blind from diabetes. And we actually have amazing evidence about what makes it better. We have amazing leaders here at Women's that are trying to implement that evidence. These things can be done. We actually know how to do them. We sometimes lack the political will. And one of the things we often lack is even the knowledge about where the gaps are, so that those who learn about these opportunities to make things better may not be the ones that really needed to do better for their patients. And so just a quick pause. Who of you here are connected to primary care? Nearly everybody. We have a very privileged group. That's great. Lovely. How many of you think that your primary care clinic knows where they're doing well and where they're not? How many of you think their primary care clinic knows which of their patients are overdue for screening for their eyes in their patients who have diabetes? Very few hands now. You're right, they don't. Why is that? Mostly political will. But if we don't look, we won't know. And if we don't know, we can't act. And we actually have tons and tons of data showing that if we provide clinicians with data about who's not up to date for stuff, they may very well act on it and help their patients. So we've led tons of work in this area, and I won't go into the details there, but we know how to do this well, and we can do it, and we are starting to. And in fact, we've led in Ontario a series of randomized trials showing that this can make a difference. I'll show just a couple of examples. Recently, co-led by a wonderful colleague called Kevin Schwartz, we've run a couple randomized trials showing that if you give doctors information about who they are and aren't, how they're prescribing their antibiotics to patients, and showing how they compare in doing that to their colleagues, maybe they can do a little bit better. And indeed, it works. And it works well enough that our friends at Ontario Health decided to make that a standard part of what all primary care clinicians are offered province-wide, which is super. Unfortunately, docs have to sign up to get data through this system, and they have to go through a whole process of accessing it with passwords and all sorts of stuff like that. And so not everybody does that. And so we took all the people that didn't yet sign up and we put them through another randomized trial showing that, hey, we really should probably do this with everybody. And we showed that, again, it works. If you give them data on their practice, they prescribe better. So we're hoping where this leads is no more signing up. Every doctor gets data that they need to do well for their patients, not just the doctors who have the span in their minds and the time and the resources to go sign up for it. So if you do give data to doctors or nurse practitioners or any kind of healthcare leader, you will predictably get one of two responses. I guarantee it. I've done it 100 times. You will hear, my patients are different, and relatedly, but not quite the same, the data are no good. And they are right. Every patient's different, in fact. And the data are never perfect. But without an attempt to know where we stand, we really can't know where we need to go next. And what they really mean, if you spend enough time with them, what they really mean to say is this. They really mean to say, I just don't know how to act on data like this. I'm trying my best already. I don't know how to do better. And it's not that they don't want to do better. They're overwhelmed because we don't have a system, as we talked about before. And one of the reasons they're also overwhelmed is that they're really busy being reactive, and they have no headspace to be proactive. And somehow, some way, we have to build those teams so that there's a little bit more capacity to start shifting where we focus our energy in primary care. Because what's happening now is, we built it, but they didn't come. And so what we've shown in multiple studies is the doctors that sign up and use this data, not only do their numbers get better, but we have an economic return on investment, which this little graph is meant to show. We actually save money in the healthcare system by doing these interventions. Not just reduce emerge visits and maybe that helps. We actually have an immediate return on investment in these initiatives. So we really want people to engage with them. But as I've said a few times before, there's an equity issue going on, and there's a little bit of the inverse care law at play. The doctors and the clinics and the nurses that have time to engage in quality improvement are often the ones already at the positive end of the spectrum of care. And so actually, there's a risk that inadvertently, we're actually widening equity gaps. We're making good doctors even better, and we're leaving others behind, which means we're leaving their patients behind. This keeps me up at night. So, on to Act 3 of this brief talk, which I wish I had 4 days for. There is an award, a leadership award, named after Jim, and it talks, earlier I said he was a good doctor because of two main things. He had clinical skill and he had emotional intelligence. This really talks about the latter. It talks about creating a work environment where people felt that they could, have psychological safety, where they could offer their ideas, where they could innovate. And I think it looks kind of like this. Primary care is really about getting in the muck with your patients and with your colleagues. I'm a little bit of an ivory tower guy, but really, being a primary care leader is about, having, your knees bent down in the mud, bailing water, along with your colleagues. And so I just want to highlight, before I run out of time, a few of the, I think, exciting ideas where we're trying to make change for and with primary care, where primary care is leading change because they're there engaging their colleagues and trying to make a difference to build the system that they and their patients deserve. So remember that image that I showed earlier on the left there, which is adapted from Dr. Schuldener's paper, where there is this disproportionate number of unvaccinated patients supported by a bunch of primary care clinics and clinicians, and those patients tend to be those who are more structurally marginalized. This was a problem. Working with OH, we decided we need to offer more resources to those clinics. And so we went to them and said, hey, we'll offer you support to contact your unvaccinated patients. We'll offer you support to provide them with automated messages or texts or emails or whatever you'd like so that you can do a better job being proactive for these patients. It turned out 2/3 of the 300 docs that we offered this to didn't have the capacity to engage with free help. They were so busy trying to do their day-to-day work that they couldn't, even if it was free, they couldn't figure out the process to do one thing more. That being said, those who engaged loved it. Free help? Sure. And so there's a lot to learn, I think, from this around how we make sure that when we offer quality improvement or make assumptions about these clinics that are really spinning their wheels, being proactive moment after, not able to be proactive, being reactive moment after moment, how we can give them the supports they need in a way that works for them. One initiative that I think is doing that pretty well is called SCOPE. SCOPE is a project that I've been part of for maybe a decade now. It started at a woman's. And it starts with the idea that it's not fair that a bunch of patients belong to doctors who aren't in teams, and those doctors don't have the support to coordinate those patients' care adequately. Not only that, it's not fair that some doctors have a little black book that's longer than others. And so, if you see those doctors, you're going to get in with a specialist really fast. And if you see another doctor that maybe is new to the area and they don't know, can't call in favors, maybe you wait longer. What kind of a system is that? And so SCOPE aims to level the playing field a little bit. It offers, especially to doctors that don't have the support of a team, basically a virtual team. Nurse navigator on call for them, a general internist on call for them, imaging on call for them, and so on, so that it looks more like a supported system. So this is very exciting work. And we started 10 years ago with 30 docs onboarded. And because of the leadership of a family doc called Pauline Pariser, who I think really exemplifies the concept of servant leadership, and I think exemplifies a bunch of the ideas that Jim's award is actually about, really has grown this now to 2,000 odd docs province-wide engaged in SCOPE because they find it valuable for them and for their patients. Docs say they can sleep better at night because they have access to these SCOPE resources. Maybe that means that fewer of them quit Maybe that means more of them continue to offer the 4C, AAA kind of care we talked about. Maybe scope helps us preserve some of the primary care system that we need. I'm going to highlight another project, also led by my wonderful colleague Jen Schuldener, who's here. We've shown, and this is a little bit inspired by, my best friend's son actually is going through ALL treatment. That's acute leukemia. He's a little boy, and when he survives it, and he will, thank God. He will grow up, and when he's a young man, because of the treatment he was exposed to, he will be at risk of serious late effects. He will be at high risk of colon cancer, for instance. He'll be at high risk of heart disease as a young man in his 20s, 30s, 40s. If he was a woman, he'd be at as high risk for breast cancer as if he carried the BRCA gene because of the treatments that he received to cure this cancer. And so we've shown that there's actually thousands of survivors of childhood cancer in our province that are now young adults, and they have no idea that they are at risk of these late effects of their cancer treatment. Their doctors probably don't know, their primary care team doesn't know, because there's no data systems currently in place to prompt them or their primary care team. So we decided to build that system. And it's launching as a randomized trial very soon to determine if it worked in partnership with Ontario Health and the Pediatric Oncology Group of Ontario. The point is that we can build systems that make sense for patients and doctors. We can't just expect the primary care clinic to know these things. If they might have one patient who's a survivor in their whole practice, to identify that one and to know the guideline that's relevant to that patient, it's an impossible expectation. We need systems. We don't just need systems for the rare patient, though. We need systems for the day-to-day work. We need systems to help us move from reactive care to proactive care, which we've talked about a few times. And so what kind of system do we need so that I know which of my patients live with diabetes and haven't had their eyes tested in 2 years? I had about 6 months ago, a patient come in that I hadn't seen in the whole pandemic. So now we're 5-6 years. And he wanted to let me focus on the sick patients, he said, which is lovely. But it turns out in the meantime, he became one of those sick patients. And now we're playing catch up, and he's overwhelmed. And so what if there was a system where we could munch our data and prompt a doc like me to reach out to a patient like that and say, hey, we haven't seen you in 5 years. We need to do this, that, and the other. We might have caught things a little earlier. So we decided to build that system. It's called Care Canvas, and it's launching this year. It takes doctors or nurse practitioners' EMR data and produces it back in a way that was co-designed with those clinicians so that they can act on it. So we're excited about that. A couple more examples of things we're working on that give me hope. I think one of the things that you've heard me express a lot is that clinicians are frustrated. They're tired. They can't keep up. They're constantly being reactive. It's really hard. And so what if there was systems in place to help clinicians support each other through the changes they need to make or to just sustain themselves going forward? There's actually quite a bit of literature now about coaching to help with burnout. The problem with coaching is that you need coaches who are expensive and take a lot of time to train and so on. And so we're toying with the idea of having basically colleagues coach each other and seeing if we can structure that in a way that's actually productive. And we're currently testing that right now. Again, with the idea that if we can help people find joy in their work and find little changes they can make, maybe they continue to practice comprehensive, continuous primary care a little bit longer rather than go do Botox. And so, I couldn't help myself. And And so one other thing to think about is if we're going to pull this off, if we're going to have teams, we need to task shift. It's no longer viable, the old Marcus Welby kind of doc. In fact, it's no longer viable to be like Dr. Ruderman. We need to task shift. Care has gotten more complicated. And so, there's the basic task shifting, like asking your medical office assistant to do some things, or asking your nurse to help you out, or getting the pharmacist involved. But we can think even more creatively, and we are. We can think creatively about what can be task shifted, how we upskill our colleagues, how we use artificial intelligence to offload some of our documentation requirements, how we can train people in the community to help support our patients who might meet with other patients to keep them up to date on chronic disease management. These are projects that I'm proud to be part of, and that I think, again, are sort of part of the solution in the long run. Okay, some take-home points because I'm out of time. So I think I've convinced most of you, I hope that primary care, a good primary care system is foundational if we're going to have an equitable and effective system. But if we're going to do that, we need primary care clinics and clinicians that are not just reactive to the day-to-day stuff. We need to be proactive. If we're going to be proactive, we're going to need data. If we're going to use that data, we need systems. If we're going to make use of a system, we need teams. What that means is that if we want to achieve the quintuple aim, we need AAA family docs or nurse practitioners supported by quadruple C clinics, and that we're doing that work now, inspired by Jim's legacy. And so I'll leave it there with a slide up talking about what some famous people said we need to keep in mind now related to the secret of care and the secret of quality. But mostly, I would urge those who are listening, especially those thinking about becoming a family doc or those working in primary care, to get involved because we are making a difference. That's all.
Thank you so much, Dr. Ivers. If you'd actually like to have a seat in one of our comfortable tub chairs over here. Hi, everyone. I'm Salmia Mayapin. I'm one of the co-chairs of this event. And thank you so much, Noah. That was such a captivating and interesting talk, very insightful. It was obviously very fitting to have you honor Dr. Ruderman's legacy by giving this lecture. I would love to open up the floor now to any questions that anyone might have. We do have a couple of mic runners on either side of the auditorium, so just put up your hand and there we go. Thanks, Rulan.
Thanks, Noah. Congratulations on all those papers we recently published. Well done. I wanted to ask, part of the thing is that you're looking at very important factors, sort of one at a time, and to prove that you've evaluated them and that you're then going to clinical practice. But you almost need to think about many things at once when you see a patient. So where is that going to be sort of a comprehensive report card per patient? Or, because Jennifer and I talk about, we're interested in blood pressure screening. And so, where are all the things that need to be done at appropriate times that happens per patient so that it isn't just one thing at a time, but the physician can see it per the patient. And in fact, then, is there a way for patients to be active in that and not just be passive? Because what I worry about is we're putting a lot on asking people to do one thing at a time, and therefore, and I totally get it for the trials, but I do worry about then how does that actually get implemented?
Yeah, thanks, Rulan. You've highlighted some really challenging things from the clinical perspective and also from how do we evaluate it effectively and how we balance those things. You're right that sometimes we have to simplify things for the purposes of evaluation and then make adaptations in the real world. One of the things that interests me most over the next few years is the concept of competing priorities. If you remember that slide where it's there's literally not enough time in the day, that's a function of competing priorities. Something's got to give. How do clinicians decide what to give? How do patients decide what should give? How do they decide those things together? And how do we enable smart decisions in regard to that is a really interesting area for ongoing research. That's not a direct answer to your question, but I think we need to do work there. I think it's true in patients' life too. I just want to highlight, the person living with 3 chronic conditions, or the elderly person living with 8 chronic conditions. Sometimes they say to me, it feels like my whole life is, taking my pills and timing it out so I can take my next one and go to my appointment and this and that. And we've failed if that's what their life is. So there are competing priorities on their end too that we have to help them with. But I think mainly what you're talking about is thinking about dashboard from not a practice level, but patient by patient level. And there is some emerging work that I've been doing with a colleague in the UK around basically moving from what we would call audit and feedback, which is kind of like aggregate patient level, what do you need to work on in general, to clinical decision support, which is point of care with the patient in front of you or on the phone or whatever, and with various prompts that ideally are prioritized. We have work to do, though. Maybe AI can help.
Great. I see a question right here.
It's a really inspirational presentation. So thank you for that. My question is around this idea of the good doctors, because I did a little bit cringe when you said that, because I thought these people who are taking on, you're saying these patients with the highest care needs and the lowest socioeconomic status with the least support, are they not good doctors too? Are they not our frontline heroes who are going it alone in rural practice all by themselves? So I just that was a thought I had when you said that. So that's not really a question. It was but my question is there a way, and it's tough when you're evaluating, you kind of let it yourself. How can you tell what's the characteristics of the population they're serving versus their performance? That's really hard to adjust for that. Mm-hmm. But is there a way, and what Roland said kind of got at it, where you could kind of evaluate against that patient's own needs as opposed to against some kind of metric which is, you know what I mean, binary? Did you implement a smoking cessation program for everyone who's a smoker? But maybe if your patient had super high needs, that was a low priority given everything else that's going on. So I guess that's when those metrics come up, I kind of go, think to the UK data on all that stuff where they tried to do pay for performance and ended up with cherry picking and things like that.
Yes. Okay. Great points. Amazing. Thank you. I agree that the concept of the good doctor is interesting and maybe controversial, and I will say explicitly that the rural family doc is a hero. The docs slogging away with not enough resources for their complex populations are absolutely good docs. I basically every clinician I think is good inside, sort of thing. When we measure stuff, often we turn them into targets, and those targets then create perverse incentives. That's what you're alluding to in the UK. So for those who are not aware, the UK used to have an amazing primary care system. They started having a lot of measurement and a lot of pay for performance. What you ended up seeing is patients having their back pain ignored because it wasn't in the pay for performance scheme. And instead during that same encounter saying, yes, but what about your diabetes? And the patient saying, but I can't walk. And that's not good primary care, clearly. And so we really have to be careful about measures turning into targets and then perverse incentives. Absolutely. I think that the 3 A's work, though. those docs who don't have the resource absolutely can still be accessible, relatively affable on a good day, and they can definitely be able in terms of their clinical skills. I don't know how we help measure that priority setting thing, though. And I think that one of the ways probably is that patients can help us by systematically reporting whether their needs were met that day. Of course, we still need to counter that with the sort of imbalance in information. Like, their perceived needs might not actually be what's most important for their health, and just recognizing that the job of the good doctor is not just to do what the patient asks for or wants, but to help them see other opportunities to improve their health. Super hard to measure.
Great questions so far. I think we have time for one or two. Okay, I see.
Hi, Noah. Thank you. Great thought-provoking talk. My question is about utilising, not just within the family healthcare team, but other resources in the community, particularly pharmacists. You mentioned pharmacists. And we have this incredible resource of highly trained pharmacists who often are close to where patients live, often highly respected, and often know a lot about their backgrounds and their partners' backgrounds and their families' backgrounds. And I work through Hypertension Canada, looking at how we can leverage pharmacists to help with blood pressure control. So we know women have very poor blood pressure control compared to men. And, looking at how we can leverage the pharmacist just for that aspect of primary care, but we could look at other areas of primary care and how that might be able to be connected to the family healthcare teams that you're trying to optimise, so that we're looking not just within a pod, but extending across and using those other highly trained professionals.
Yeah, I had slides about community pharmacy, but time. So I totally agree with what you're saying. You of course, will be familiar with the large trials of having community pharmacists engage in hypertension control in Canada, where we actually reduced stroke, which is, an amazing accomplishment. Lisa Dolovich led that work. So this is doable, but then, the pharmacists need to be supported appropriately to do that work. And not incentivized to do low-yield work, which is, I think, a fair way of phrasing it. And most interesting to me is how we do that as a team. So in those trials, those community pharmacists engaging in that hypertension work were very much integrated information-wise with in those trials, the family doc in those communities. So these are generally small communities, you're right. Actually, that image that I said, way more, the most healthcare encounters are with GPs. It's actually not true. Most healthcare encounters are with community pharmacists, if we include that in the counting. So you're absolutely right. This is something we should leverage. How do we leverage it in a way that makes continuity of information and a team, rather than folks competing with each other and turf wars and stuff that seems silly to me? I don't know the answer to that, but it feels like the answer has something to do with politics. Aren't those the same?
Thank you so much, everyone. Noah, you did an amazing job staying on time, and it actually does take us well into our first break. Can we get another round of applause for Dr. Ivers?